Hi, it's Matt Gary. We're going to be going over esotropia in this session. The first half of the session will be this online lecture. The second half will be performed in the lecture hall with a discussion of the management of esotropia. So what I want us to do in this session is to develop a classification and treatment scheme for esotropic patients based on both the clinical history and the examination findings. Specific objectives include the ability to list 4 clinical characteristics of infantile esotropia. You should be able to describe the typical clinical course of a patient with accommodative esotropia. And lastly, you should be able to outline the diagnostic steps in a patient with concomitant esotropia. So the BCSC volume breaks esotropia down into 5 general categories. The first is pseudoesotropia. Second is infantile, or some people call it congenital esotropia. Then there's the group of accommodative esotropia, which both includes refractive, which is typical accommodative esotropia, as well as non-refractive, which is called high ACA ratio accommodative esotropia. The last 2 are non-accommodative acquired esotropia and concomitant esotropia. As a general overview of esotropia, it's the most common direction of pediatric strabismus. The fusional state can either be aphoria, an intermittent tropia, or consentropia, and deviation may either be combinant or concomitant. Pseudoesotropia is very common, especially in patients younger than a year and a half of age. It's probably 10 to 20% of my patients with esotropia coming into my office. It's either caused by epicanthal folds or a broad base of the nose which covers the nasal sclera, and the parents may notice it only in pictures like in these 2 examples. You can diagnose it in the office by having a centered corneal reflex as well as nose shifting on cover testing. Here's our first quiz question of the day, which is not a characteristic of infantile esotropia. Frequent amblyopia, frequent cross-fixation, large angle of esotropia, or onset before 6 months of age. Okay, we're going to discuss infantile esotropia. It's fairly uncommon, but it is a large angle esotropia, usually greater than 30 and often up to 40 or 50 prism diopters. And it's diagnosed in the first 6 months of life, either by parental report or by pictures. These patients tend to cross-fixate, so the right eye looks to the left and left eye looks to the right. So they have a low incidence of amblyopia. Sometimes it's difficult to elicit full abduction in these patients because they tend to cross-fixate. You can either get them to move the eye into abduction by doing a doll's head maneuver or sitting and rotating the patient to get them to rotate the eyes into abduction. The basis of infantile esotropia is thought to either be a lack of binocularly driven cortical neurons or possibly a mechanical process. It's a little bit of a chicken and egg question on which causes which in that situation. Some patients with early onset esotropia may have a high amount of hyperopia. In these patients, I tend to give the full cyclopedic refraction to see if they improve. Early surgery is recommended. Usually you can get decent results if you operate before 6 months from the onset of the esotropia. And this may offer some amount of binocularity. Usually I'd perform a bilateral medial rectus recession and possibly adding a lateral rectus resection if the deviation is greater than 50 prism diopters. These patients tend to develop subsequent strabismus, including inferior oblique overaction, dissociated vertical deviation, and latent nystagmus. Okay, for accommodative esotropia, the onset's later than the congenital esotropes, usually between a year and a half and 3 years of age, although it can be somewhat younger or later than this. It tends to be intermittent at the start, and it can be hereditary. They have a moderate to high amount of hyperopia, like +3 to +8. They can get amblyopia as well, especially if there's anispotropia. You'll see in the picture here, the top picture is with the child without correction, and the bottom picture is with this hyperopic correction with straighter eyes. For the typical accommodative esotrope, the esotrope is similar distance and near, and it's thought that uncorrected hyperopia leads to accommodative convergence, and if there's a lack of fusional divergence, the eyes cross. I typically give the full cyclopedic refraction to start unless they're very hyperopic, and you can then wean the prescription with time to encourage fusional divergence. I will re-refract the patient and update the glasses if the esotropia occurs in their current glasses. This next group of patients is what we call a high ACA ratio esotropia. The BCSC has the rather longer term non-refractive accommodative esotropia. These patients usually have mild or hyperopia and sometimes even are myopic, and they typically have an esotropia that's greater at near than distance, and their AC ratio is high, greater than 5. In these patients, we will give them their cycloplegic refraction with a bifocal, typically starting with a +3, and we want the bifocal to sit up high so it's split in the pupil. Then we can wean the bifocal power as tolerated. So if a patient comes back for a follow-up visit and they're doing well in their +3s, I'll hold up a -1 lens in front of their bifocals and see if they can still control this, and then wean as tolerated. In the pictures on the right-hand side of the slide here, we have the patient at the top that's uncorrected, so he has a little esotropia. When he gets his glasses and he's looking at distance or the top of the bifocal, his eyes are straight. If he's looking at near in the third panel here, the eyes are estropic. When you move into his bifocal, the eyes straighten out. So this is the typical appearance of a high ACA ratio estrope. Okay, to understand the ACA ratio, you have to understand the near triad, which is accommodation, convergence, and meiosis. And since accommodation is usually on a near target, the visual axes are supposed to converge. It's interesting that when you look at testing in the lab, convergence typically is pretty accurate, but the accommodation can be somewhat sloppy. So our exact measurement can vary depending upon how hard the patient's trying. There are two ways to calculate the ACA ratio, and we'll probably go over this in the lecture hall because it's a little bit easier than just trying to write it out like this. What I typically use in the office is the gradient method, where we measure the esotropia near, and then we measure the esotropia near with a +3 lens in front of the eyes. This is going to decrease their accommodative demand. And then calculate the ACA ratio as the ET at near without the +3 lens, subtract the ET at near with the +3 lens, and divide by 3. And normal value for this is about 3 or 4. The heterophobia method requires you to measure their interpupillary distance and account for their deviation of distance and near. I tend not to do this. One drug to be aware of, at least for testing sake, is phospholene iodide. This used to be used quite frequently for both glaucoma patients and patients with accommodative and high ACD ratio esotropia. It's a long-acting cholinesterase inhibitor, so it can be used in accommodative estropes and high ACD ratio estropes, either in place of glasses or to help get them out of bifocals. And it acts by increasing the acetylcholine available in the ciliary body, so you need less innervation needed for each unit of accommodation, so you get less convergence. You have to warn the patients about acetylcholine and other non-depolarizing muscle relaxants because it can cause prolonged paralysis. The last group of the accommodative estropes is the partially accommodative estrope. These patients usually have control of their esotropia with their refraction initially, and then they tend to break down and have crossing with the glasses on. It's important to re-refract these patients to see if you can correct their residual esotropia. It tends to be more common if the initial glasses prescription is delayed, and then you can operate for the non-accommodative components. So if the patient is in their glasses and has an ET of 20, and without the glasses the ET is 40, you want to operate for that 20 and keep them in the glasses afterwards. Okay, we finished up the accommodative section of esotropia. We'll move on to the acquired esotropias. And the first one we'll consider is basic esotropia. This is where this deviation is similar at distance and near. It comes on after 6 months and it's non-accommodative, so it's not an infantile or accommodative esotropia. It can be a sign of a CNS lesion, so if there's any neurological signs or developmental delays, you might consider scanning these patients. If the workup's negative or they're not concerned about neurological issues, you can do bilateral medial electricity sessions for this condition. Some authors advise prism adaptation for basic esotropia. This is where you'll measure the esotropia, correct it with a temporary prism in the glasses, and send them home for a week or two, and bring them back to see if that esotropia builds up. This is thought to happen in some patients with ARC, and the prism adaptation trial showed less instance of undercorrection or residual esotropia in patients who underwent prism adaptation versus those who didn't. Occasionally, basic esotropia can come on after occlusion, either with patching or because of an injury, and rarely in young patients it can be cyclical, where they have days of esotropia and days of straight eyes, alternating back and forth. Sensory esotropia is another cause of an acquired esotropia. It tends to be in cases of amblyopia or an organic lesion, the eye with the poor vision will cross in. Kids, for some reason, tend towards sensory esotropia, where adults tend to become exotropic with sensory conditions. In these patients, you often do a recess resect on the poor seeing eye. Divergence insufficiency is an interesting esotropia that is acquired and usually happens in adults. It's where the esotropia is greater at distance. Sometimes these are primary cases and they may resolve in 4 or 6 months, and it can be a sign of a mild sixth-nerve palsy or a pontine lesion, so you may consider scanning these patients. One interesting recent development is the description of the sagging eye syndrome by Joe Deemer, and with MRI imaging of the orbit, he showed rupture of the superior rectus lateral band, part of the pulley system, which causes the lateral rectus to sag inferiorly in the orbit. In this situation, they get a picture that's very similar to divergence insufficiency. Options for these patients are scanning if there's any neurological worries, bilateral rectus resections, or in sagging eye syndrome, you can do a lateral rectus to superior rectus union with a suture. Or if the patient has a small angle, they can have a base out prism. Another interesting case of acquired esotropia, usually in adults, is near spasm or spasm of the near triad. These patients will have esotropia as well as accommodative spasm, which causes pseudomyopia and blurring of their vision, as well as miosis of the pupils. One characteristic pattern these patients have is they'll substitute convergence for lateral versions in the lateral gaze. So instead of adducting the eye, they'll have convergence. And if you check one at a time, the ductions or monocular rotations tend to be much better than the versions with both eyes together. These patients can be treated with atropine and or bifocals to help break their spasm and have them see well. The last cause of acquired esotropia is consecutive esotropia. This is esotropia that occurs after surgery for an exotropia. You can treat these patients with hyperopic spectacles if they are hyperopic. We mentioned earlier phosphine iodide can be used for overcorrections, as well as re-op if necessary. One thing you need to watch for in these patients is to make sure in their first post-op visit that they don't have any limitation of full duction, because you can have a lost or slipped muscle. So if they have complete lack of rotation in the field of action of the muscle you operate on, you might want to go in early to explore that to pull that muscle back up. The last quiz question of the day, and this is worded a little bit differently than past years, so bear with me here. Which of the following does not help distinguish sixth nerve palsy from Duane syndrome? Globe retraction, alignment in primary position, presence of a face turn, or exotropia in contralateral gaze? Okay, the last section of the esotropia chapter in the book is incontinent esotropia, and we'll go over a little bit more of these in the special sections lecture. But briefly, the sixth nerve palsy, the esotropia is worst to the side of the paretic lateral rectus. A third of these in children may have intracranial lesions, so you might want to consider scanning them. Duane syndrome looks like a sixth nerve palsy, but usually has relatively straight eyes in primary position. They typically get fissure narrowing on adduction as well. The last two causes are cause of restriction of the medial rectus, thyroid eye disease, and medial wall fractures that can cause an incontinent esotropia. The next 4 slides are going to be photo montages of gaze positions in 4 patients with incontinent strabismus. So look them over, look at the adducting eye, look at the limitation of abduction, and see if you can figure out what these diseases might be. And when you finish up with those, we'll have rounding out the post-test quizzes. Final test question number 1, which is not a characteristic of infantile esotropia? A, frequent amblyopia, B, frequent cross-fixation, C, large angle esotropia, or D, onset before 6 months of age? Pause, consider your answer, and I'll be back in a second. Okay, so the answer for this of which is not a characteristic of infantile esotropia is actually A, frequent amblyopia. Most patients with infantile esotropia will cross-fixate and have not a high incidence of amblyopia at all. Okay, quiz question number 2, which is a characteristic of refractive accompanied esotropia? A, onset before 6 months of age. B, the esotropia decreases with full cyclopedic refraction. C, a large angle esotropia like 50 prism wrappers. Or D, usually requires surgery. Pause and come back when you're ready. The correct answer here